Some of the OASIS scores derived from the start of care assessment are compiled on the next two slides of your review. These scores and related assessment findings will help to support Leroy's skilled service needs. Our findings can help us in care planning and in creating meaningful and functional goals with and for Leroy. A DVD of our Rehab Council presentation on OASIS scoring competency was created in 2010 and is available for purchase through the Minnesota Home Care Association. Now getting back to Leroy, the score for M1240 pain assessment is 2, yes, and it indicates severe pain. For M1242, frequency of pain interfering with the patient's activity or movement, the score is 4, all of the time. For M1340, surgical wound, the score is 1, yes. Leroy does have at least one surgical wound. However, we are no longer required to count the wounds for the purpose of OASIS scoring. M1342, the most problematic surgical wound status is 3, not healing. M2020, management of oral medications, is scored 3, unable to take medications unless administered by another person. This score is a change from our 2010 training due to subsequent CMS clarifications. Safety in ambulation is a factor affecting Leroy's independence in obtaining and administering his medications and in obtaining the water needed to swallow his pills. For M1960, ambulation, the score is 3, able to walk only with the supervision or assistance of another person at all times. Safety is a key factor in scoring for Leroy's ability to ambulate over a variety of surfaces. M1610, urinary incontinence, the score is 1. The patient is incontinent. For M1615, when the urinary incontinence occurs, is a 3, during the day only. And now there's further comment on that as far as it could be marked further lower, but again, that is another discussion that you'll have to get from our other video. M1850 transfers, 2, able to bear weight and pivot during the transfer process, but unable to transfer self. M1830 bathing, the answer is either 4 or a 5. We weren't able to clarify within our video whether he was receiving assistance with sponge bathing, but he is unable to use the shower or tub. M1400, dyspnea. He is dyspneic. He scored a 2 with moderate exertion. For further discussion on the OASIS information, again, you may view the prior DVD, the Transdisciplinary Competency Skills for OASIS, and always be aware of CMS's quarterly Q&As, the guidance we receive from CMS, which may change how the OASIS data is answered based upon revised interpretations. Okay, so we now have a clinical summary which uses an SBAR format for Leroy. It is included on the next 4 slides. We'll review this information to set the stage for further care planning. So we have the situation. A 75-year-old pleasant male assessed after a 3-day hospital stay post right total knee arthroplasty. The background. The patient lives with his spouse in his own home with 3 steps entering the home and a shower in the basement. He has 1 son, 1 daughter, and 1 son-in-law who are supportive and assisting them with meals, groceries, and homemaking tasks. His spouse is helping with medications since returning home, and past medical history includes hypertension, left total knee in 2008, pulmonary fibrosis, and osteoarthritis in multiple sites. For our assessment, we have Leroy demonstrating moderate edema in his right calf and ankle. His surgical incisions are healing as expected for a post-op time frame with no signs of infection. His pain is severe and limits his activity. He demonstrates forgetfulness, especially with medication management, and may benefit from a cognitive assessment. His functional mobility is difficult with transfers, and he needs cues for safe ambulation with a walker with limited tolerance with distance. He is short of breath, and this is demonstrated with moderate activity. He has difficulty with ADLs due to lower extremity range limitation and pain. Our recommendations. Nursing needs to provide medication teaching, monitor edema, monitor the incision, and do labs for the INR, and do some pain management. There is going to be a referral for physical therapy to assess mobility and to also watch for edema, pain, and the incision, and for OT to assess ADLs. And here is Leroy's current medication list. He's on Vicodin, Coumadin, a multivitamin, Toprol. He uses an Acuneb, and he's on ibuprofen. Goal writing starts with the evaluation. We need objective baseline measures in order to document progress. We need to measure impairments in order to identify that we have made a difference with our interventions. You may reference the PT, OT, and nursing evaluations in your handouts for further information. Now we move to the NAJI model. This is a conceptual model of disablement developed by Dr. Saad Naji. It is accepted and utilized by the World Health Organization. It guides our clinical reasoning, which helps us to accurately identify appropriate and attainable goals, as well as to document our reasoning to support our services. Here's an example of the NAJI model used for a patient who's had a CVA. In this case, the pathology is the damage to the brain cells. The impairment is the CNS dysfunction, which shows up as weakness and sensory loss. The functional limitations are the changes in safety and independence with bed mobility, toilet transfers, and ambulation ADLs. The disability is the resulting inability to care for children, to work as a plumber, or to access the office or home environment. The disability is not just the state of a person, but the interaction of the person in his or her environment. Consider how the OASIS question regarding steps to enter the home could be used to support services which would address a disability related to home access. Disciplines may treat patients and form goals using different levels of this disablement model. Nursing often treats impairment. For example, the patient who is post-CVA will need services for medication management and INRs. The PT may address the impairment with the use of heat and stretching to decrease spasticity, or exercises to work on weakness and muscle imbalance. They may work towards functional goals, such as safe bed mobility, transfers, and ambulation. They may also create disability goals as they pertain to work, with car transfer training to enable workplace access. The OT will work towards functional improvements for ADLs, toileting, bathing, and cooking. They will also work on disability goals integrating function and the environment to limit disability with recommendations for items such as grab bars, a tub transfer bench, or kitchen and utensil modifications. Now, we are commissioned as professional clinicians to work in collaboration with our patients to establish meaningful care plan goals. These goals are the intended results of the services that we provide. Goals are the drivers for our interventions. In order for our written goals to justify payment for our services, they need to be SMART. And when I say SMART, Kristen, I mean they should not be stupid. Allow us to elaborate on the components of both SMART and stupid goals so that we can make our points. To further illustrate the SMART and stupid concepts that we will be presenting, we will be wearing two hats. Just play along with us on this one, please. Linda, you can have this hat. Why, thank you, Kristen. Now, we will start with the first two letters of the word stupid. S stands for subjective, and T stands for too vague. Here's an example of this kind of goal. The patient will demonstrate improved activity tolerance. Will this goal paint a clear picture of what improvement should look like? No, it is too vague. It does not define the activity or activities to be tolerated. Will it give us any objective data to support our services?
No, it is too subjective. There are no observable parameters to define the outcome for the patient.
Now, if we take the first two letters, in the word SMART, we come up with two quality words for goal writing, specific and measurable. So how can we describe improved activity tolerance in a way that is both specific and measurable? Let's try this one. The patient will dress herself independently in 10 minutes without exhibiting any shortness of breath. This goal is both specific and measurable.
Okay, let's try another stupid goal, taking the U from the word stupid, which stands for the word unrealistic. To set the stage, our patient came home 3 days post-surgery following a total knee replacement. He has pain rated at 6 of 10 most of the time, and he is holding his knee rigid when he walks with a walker. What are your thoughts on this goal? In 2 weeks, the patient will walk independently with no pain. Now, my experience tells me that this goal may not be too realistic. We use our professional experience, our clinical judgment, and our evidence-based practice to establish realistic timeframes and goals for our patients.
We also need to consider what the patient's prior level of function was when we set our goals. And then we can choose goals that fit the third letter in the word SMART. A is for attainable. Here's a more attainable goal for a patient who is just home following knee replacement surgery. In 2 weeks, the patient will walk safely in his home without a limp, using a cane, and with pain managed at 3 of 10 or less.
Now, Kristen, I say that since we're the professionals, we have the experience to create goals, and we don't need to rely on our patients to set them for us.
Whoa. Stop right there. Has anyone ever fallen into the stupid trap of thinking that we know what's best for our patients without consulting them? We may have professional expertise, but unless we have the patient and often the caregivers as well involved and on board with the care plan, and unless we know what the patient's ultimate objective is, we are missing the boat with setting goals. The goals belong to the patient.
Okay, so here is a well-written goal that is stupid. The P in stupid stands for plan without patient. This goal is stupid by virtue of no patient involvement. Here's the goal. Patient will don his TED stockings independently using a sock aid. In this instance, the patient plans to have his wife assist with his TED stockings. He has no intention of using a sock aid.
Now here's the same goal, but with the patient on board, it is R for relevant. And now that makes it SMART. The patient will don his TED stockings independently using a sock aid. He doesn't want any help from anybody. He wants to do it himself. One final component of SMART versus stupid is that the SMART goal establishes a specific duration of time in which we would anticipate the patient to meet his or her goals. It may include a time frame such as 2 weeks or a specific target date such as June 1st, 2012.
Okay, it's easy for me to be stupid on this item. I'll just set a goal that is I for indefinite. Here's an example. The patient will be independent in setting up his oral medications. Where's the time frame?
Let's just add a time frame so that this goal is time limited, the final T in the word SMART. In 2 weeks, the patient will be independent in setting up his oral medications using a weekly pill box. I added the pill box to this goal because I am smart, and I think it might help this patient be successful in achieving his goal within the predicted time frame if he uses a tool.